have. Okay, so let me pass you over to People That Delivers Executive Manager Dominique Zwinkels, who will take it from here.
Thank you, Jonathan, and good afternoon and good morning to everyone. As Jonathan said, my name is Dominique Zwinkels, and I'm the Executive Manager of the People That Deliver. So just quickly, the People That Deliver is a global coalition of 26 organizations that is working towards strengthening the capacity of the health supply chain workforce while promoting the professionalization of the supply chain role within the broader health system. We are known as the global technical leader for human resources for supply chain management for lower and middle income countries. And we advocate for a systematic approach to human resources for health supply chain management. As a coalition, we're working together to achieve one long-term goal, which is to create a competent, supported, and effectively staffed supply chain workforce that's deployed across both the public and private sectors within the health system. There's a real need to increase coordination around what makes a supply chain professional, so that employees in the public and private sector can ask for the right people with the right qualifications, and so that academic institutions and professional associations can produce the professionals to meet that market. In today's webinar, we're going to focus on the community health worker in the supply chain, and which is an often overlooked but an important cadre of worker that ensures health products reach the patients that need them. We'll be sharing with you the findings and recommendations from a recent study we performed in Liberia, together with our coalition member VillageReach and financially supported by USAID. So I'm honored today to have an esteemed panel joining us with a special guest, Mr. James Duwoe. He's a community health assistant from Liberia who traveled from his community of Bomi County to Monrovia to join us today. We are also joined by John Tutu Harris, Ms. Lusubiro Mwamsamali, Ms. Jannie Horace, and Dr. Lennie Bazira. Just a little background to each of these individuals. Mr. John T. Harris, who is known as JT in Liberia, is a seasoned pharmacy supply chain and logistics expert who is passionate about access to medicines for all. In his role as a director of supply chain for the Division of Pharmaceutical Services, the chief pharmacist, he has spearheaded the deployment of the Pharmacy and Supply Chain for Community Health Workers initiative, as he strongly believes community health assistants are key to reducing the burden on health facilities and that they need to be supplied to provide the basic primary health services in their communities. We're also joined by Lusubiro Mwamsamali. She is a pharma economist and a global health supply chain expert currently serving as the country lead for VillageReach in Liberia, where she provides technical oversight for the supply chain for community health workers portfolio. She is passionate about health equity, financing, and increasing access to medicines for the underserved. And then I wanted to add that Dr. Lennie Bazira is the Director of Policy for the Community Health Impact Coalition, and our work corresponds to the central advocacy message of the Community Health Impact Coalition, in that community health workers should be salaried, skilled, supervised, and supplied. We also have Jannie Horace, who's the Community Health Services Specialist, and of course, James Duwoe. James is a community health assistant from the Biya community in Bomi County. He has served his community in his role for close to 7 years, and he is the current president for Community Health Assistants in Bomi County. He is a former volunteer with Red Cross International and is a certified facilitator in first aid training and serves as the focal person for disaster management in Bomi. He's also a preacher and a farmer, and he loves growing peppers. So I'm very excited to have this panel with us today. I am now going to just introduce a few pieces about people that deliver. As many of you are familiar with the supply chain, this graph will show you very closely how the supply chain is an interconnected system involving flows of goods, funds, and data. This image was provided to us by Gavi, the Vaccine Alliance, and it shows how the global supply chain feeds into the country's supply chain, where supplies arrive in the country and then are distributed to national and subnational stores. The end of the line is distribution to health centers and service delivery. Health programs require many health supplies, and these health supplies must reach service delivery points and the patients through these long and complex supply chains. The health supply chain requires many professionals because it is a complex workforce and highly specialized. The supply chain workforce includes a variety of people who are dedicated to supply chain and logistics activities at national, district, and health facility levels. It also includes key personnel who contribute only a portion of their time to supply chain functions, but all are collectively tasked to ensure the appropriate commodity selection, quantification, and forecasting, procurement, storage, distribution, stock management, and use of health products. As you can hear, a lot of different domains are included. Next slide, please. So why do we focus on human resources for supply chain management? From research that we have done within the people that deliver, the following challenges all cause a reduction in supply chain performance because of workforce-related issues. It starts off with the fragmentation of the responsibility for managing the overall performance of the supply chain. It then moves to lack of planning and financing for the workforce, to lack of development and credentialing for supply chain managers, to lack of accurate job descriptions, and lack of professional development and professional associations. But as you know, within the people that deliver, we're currently addressing all of these different issues. Next slide, please. As I mentioned earlier, the supply chain workforce includes a variety of people who are dedicated to fulfilling supply chain management activities at national, district, and health facility levels, such as pharmacists, logisticians, supply chain managers, data managers, warehouse and transportation personnel. The aim of the supply chain management system is to ensure that products are available to the end user at the right time, in the right quantities, at the right quality, and at the right price. This requires a professional, competent, and motivated workforce at all levels of the supply chain, including the community level, as you'll see here that I've circled at the bottom. Community health workers and their supervisors are an integral part of the health supply chain workforce. Community health workers are individuals selected to provide health services at the community level. They often live in the same communities in which they serve and are therefore well-versed in local culture, language, customs, and social norms. Community health workers undergo training to gain the knowledge and develop the skills necessary to deliver culturally appropriate services within their scope of work. Community health workers engage community members during household visits, at which time they conduct health assessments and screenings, promote health, and provide referrals to the health facility. The National Community Health Assistant Program for Liberia was launched in 2016. It formally recognizes community health assistants as members of the health system in Liberia and are selected by members of their own communities to whom they are held accountable. The National Community Health Services Policy of 2016 to 2021, endorsed by the Ministry of Health in Liberia, stipulates the community health assistants must be permanent residents of the communities in which they serve, and community health assistants serve in communities located more than 5 kilometers from the nearest health facility. Next slide, please. And so this brings us to the people that deliver theory of change and the application in Liberia. As many of you who are on the webinar today may know that our foundational approach to human resources for health supply chain management lies in our theory of change. This theory of change was developed in 2018, and it centers around 4 pathways: staffing, skills, working conditions, and motivation. These are the conditions that are needed to ensure that workers at every level of the supply chain perform optimally and impact the availability of health commodities. The theory of change was created to help with improving policies in key public and private sector entities, and to also increase and improve resources for government, non-government, national, and international to support a qualified, educated health supply chain workforce. And finally, it was also developed to improve mechanisms to support the professionalization of a qualified and educated health supply chain workforce. In many settings, community health level stockouts remain a persistent challenge and impede the ability of community health workers to deliver health services. A recent systematic review published in 2022 in the Human Resources for Health journal found that community health workers were out of stock nearly 1/3 of the time. The needs of the community health workers as they relate to staffing, skills, motivation, and working conditions may differ from health supply chain workers at other levels of the supply chain. We therefore examined and explored the barriers related to staffing, skills, working conditions, and motivation from the perspective of community health workers and community health service supervisors. Next slide, please. And so just wanted to provide you a summary of the key findings from our study in Liberia. A purposive sample of community health assistants and community health service supervisors was selected in the counties of Margibi, Grand Bassa, and Bong. Focus group discussions were used to collect data from 24 community health assistants and 24 supervisors. Discussions with them were conducted separately to promote frank discussions. These discussions centered on the working conditions of the assistants and included supply chain questions as well as general inquiries from the levels of staffing, skills, and motivation of the assistants. The findings from the study reinforce the need to consider the overall health supply chain system in which community health workers work when applying the theory of change. Assistants and their supervisors undergo extensive training prior to commencing their roles. There's a very strong learning and skills development program, and mentoring has been very successful. Assistants and supervisors report confidence in their ability to complete supply chain tasks, such as completion of tracking forms and maintenance of the commodities. But most community health assistants lack the supplies necessary to fulfill their roles. Likewise, the availability of essential medication remains a persistent challenge at community level, resulting in referrals to the facility, many of which are not taken up due to distance as well as cost. Pride and respect are key motivators for community health assistants, as is a desire to promote community health. A lack of commodities at community level erodes community confidence in the community health assistant. Working conditions and motivation are the pathways that require attention, as we found in our study. 20% of essential medicines are normally earmarked for community use. This, however, does not occur in practice. Medication designated for community use is often close to its expiry date. Assistants describe a complex reporting process that includes no fewer than 7 data collection ledgers, as well as a commodity tracking form on which they document consumption. Even with this reporting process in place, supervisors across all 3 counties reported receiving insufficient commodities with which to restock the health community assistance. The assistants do not have access to benefits such as medical insurance or leave, and therefore assume a substantial amount of risk as they undertake their work. In addition, many assistants are responsible for up to 4 times the number of households designated in the Liberian National Community Health Service Policy, which stipulates 60 households. Despite inflation, monthly stipends provided to assistants have remained the same since inception of the national program, which was in 2016. So these are some of our key findings. And I think now it's time to move to round 1 of questions so we can actually hear our panel speak, and they can dig a little deeper into some of the findings that we have found through our study. So round 1, we're going to set the scene, and we'd like to ask this question to Lusu from VillageReach. So tell us about the work you've been doing at the last mile with community health assistants in Liberia, the improvements you've seen and the issues that remain. So over to you.
Thank you so much, Dominique, for your question. VillageReach has been operating in Liberia since 2019. We have been working with the Ministry of Health Supply Chain Management Unit and the Community Health Services Division, and also the county health teams, facilities, and the community health assistants themselves with the aim of improving commodity availability and accessibility. So mainly we strongly believe that people who have overcome incredible barriers to reaching a healthcare worker should not be turned away because the medicines needed to treat their conditions are not there. So our work over the years has mainly focused on identifying and understanding the systemic supply chain bottlenecks that prevent the CHWs from accessing the commodities that they need to be able to provide the life-saving services. And in addition to that, we have also been actively co-creating innovative solutions with both the government partners and CHWs themselves to identify ways to be able to improve how the CHWs can unveil the needed commodities. And most importantly, we have been also advocating for the integration of the community health supply chain, which is largely partner-driven and heavily fragmented, making it impossible for government or anyone to have actual visibility into the commodity needs and the gaps that exist. So despite all these issues, however, we have seen largely improvements based on some of the solutions that we have deployed. Of major interest under the workforce capacity development. So under this one, when we're starting our initiatives, the community health services, most of the community health services supervisors were not trained in basic inventory management and logistics management information systems, and also in supply chain SOPs. So we have been able to do that in the counties that we work in, which has helped to improve the quarterly LMIS reporting rate to almost 100%. So what that means is that has helped to position the community health program to be able to access commodities based on their consumption from the government cake. And secondly, based off of that same data, we have also been able to quantify the community health commodity needs. So we have also been able to include these not just in the essential medicines program, but also in other programs such as malaria and reproductive health. Of key note is the first quantification that happened in Liberia was in 2021, which was able to provide a true, to be able to provide a true commodity needs for the CHWs, which has been used also to be socialized to both donors and partners, and has also been included in the National Community Health Policy and Strategy to solicit funding for the same. And a major also improvement that we have seen is the strong buy-in from government for community health supply chains. So this can be attested by the inclusion of the community health supply chain into the supply chain master plan. What that means is that the community health now is like a recognized supply chain tier in the overall national supply chain system, positioning it for better investments from both government and also partners. So despite all these major improvements that we've seen, there still are several issues that remain. Mainly is the lack of a dedicated supply chain cadre to manage last mile supply chains. What that means is at the moment in the supply chain design, the human resources are only allocated up to the county level. So beyond the county level, we mainly have volunteers who are responsible for managing products and also the data needed to process requisitions. So the lack of that dedicated expertise presents as a major gap that needs to be addressed so that community health assistants can continuously be able to access the commodities that they need. And then secondly, the issue of stockouts. We are still having issues with regular availability of these commodities. So at the moment, there's still heavy rationing of commodities, which makes it challenging for the community health assistants to be able to access, as the priority is usually facilities and also referral hospitals. And then the other challenge as well that still remains is the limited visibility into the actual commodity needs and demand. Basically, at the moment, it takes a minimum of 90 days for someone at the national level and also at the county health to be able to access the data on consumption for decision making. So what that means is if there's a stock out that happened in January, you will only be able to see it on the ELMIS around April, May. So there's need to be able to reduce that gap so that the system is proactive in responding to stockouts. Thank you so much.
Thank you, Lusu. Yeah, very interesting though to hear about the 2021 quantification. I think that is going to make significant improvements in the system. So over to James. Yeah, let's see. Yeah, thank you. Can you explain your role in the supply chain and what do you see as the obstacles to fully performing your role and meeting the needs of your patients? So over to you, James.
Thank you, Dominique, for the question. As it relates to my role in the supply chain, I should be able to do a monthly report of whatever that is being provided to me as a CHA in my community. That will help the health facility to get the understanding that I'm treating people at the level of the community. The second thing I need to do is to make sure I account for every commodity that is given to me as a CHA in my community. I must be able to account for them. So meaning that I should have them properly recorded in my ledger as long as I continue to serve as a community health assistant. The number three thing I need to do is to make sure that those stocks are managed and managed very well. Every commodity supplied to me should be kept in my supply box so that they will be able to be staying away from the reach of children. And they can also stay away from the smaller animal called rats in our community, and make sure that the box is completely locked until there's a need for it to be open. If that is done, meaning that those commodities are managed very well. And those commodities are managed as well, we should be able to have a plan to work along with the community health services supervisor. If some commodities are running low, we should be able to report ahead of time so that we will be able to be restocked so that there can be a gap in the supply chain. Or if there's a commodity, for example, ORS is given to me and they are more and they will soon be expired maybe in 3 months' time, I should be able to work along with the CHSS so that some of the ORS can be taken from my community to another community for the proper use so that it cannot get expired. As it relates to what I see as obstacles or challenges in performing my role, we are challenged so much as it relates to drug supply. The irregular drug supply to our community is a serious challenge for us. You will notice that we have lost trust of our community because we don't have drugs in the community. Sometimes we go a year or year plus to receive drug supply, and that is not actually good for us. The second challenge we have is the distances we cover to treat children. Sometimes we walk 1 hour, 45 minutes, sometimes 2 hours in communities that are satellite community to our communities because CHA is not everywhere in all of our communities. So we have to be able to reach those communities to treat children from those particular satellite communities. It's a long distance walking back and forth. The number 3 challenges we have as well, it has to do with transportation on the basis of these distances. So you notice that we are constrained to the point where we have to take the small incentive that is given to me to buy a motorbike that I will be able to ride on to go from one village to another to be able to treat the children from the little incentive that is being given to me. Another challenge we have, it has to do with ring gear. When we are giving a ring gear suit, that sometimes runs for like 2 years. And sometimes it's just a week. The ring gears are not too strong and they get damaged. So we have to take money from our little incentive to buy a set of ring gear in Liberia. It's $25 USD out of our little incentive that I've done over the year. I sometimes use my motorbike to carry pregnant women to the health facility, or sometimes to carry children who are referred and their mother cannot afford the amount to pay their way to and fro. So sometimes we use our bike to carry this mother to the health facility to help them to wait and their children are treated, then we bring them back in the community. So these are situations or circumstances we are going through as challenges in our community. And these things are hammocking us so much. The community doesn't even have trust in us. They call us names, they call us either Mr. Referral, or sometimes they call us Mr. Liar, because we were trained to treat 3 different communities, sicknesses in our community. That has to do with diarrhea, malaria, and pneumonia. You will not understand that from the day we were trained up to present, we haven't been able to see one, amoxicillin in our community. So that tells you that we have not been able to treat one case of pneumonia in our community over the period of time we were trained. So these things are not really good for us because it's actually a serious challenge for the community. The community doesn't trust us. They doesn't see us as a help any longer to the community as they were expecting us to be unto them, because every cases we receive, we have to give a referral to the health facility. Sometimes some mother will not honor it because there's no money to take the children to the health facility. Thank you so much.
Thank you, James. First of all, I'm happy to hear that you're able to manage your stocks well, keeping them in the box, managing those commodities. That's excellent. But this issue around the lost trust by community is disappointing, and I understand that that is a big obstacle. So I'm going to now move on to our next panelist, and that's John Tutu Harris. Arthur, I have enabled your mic. Is John with you?
Yes, John is with me, and I.
Okay,
Yes.
great.
Hello.
Hello, John. I have a question. I actually have 2 questions for you. So welcome, very happy to have you here as well. So the first question is, what are your priorities in terms of providing access to health products and services at the last mile? And then my second question is, have you considered the theory of change and the 4 pathways, meaning staffing, skills, motivation, and working conditions, as a tool to support community health assistants in fulfilling their tasks? So over to you. Arthur, I see your mic is muted. Can you unmute yourself? Okay. I think in the meantime, just for the sake of keeping this going, we'll move on to Jannie Horace from USAID Liberia. And my question to you, Jannie, is if you can tell us about the investments you have made as USAID to support community health assistance in Liberia, what your main priorities are, and how you're supporting the Ministry of Health. Over to you.
Thank you, Dominique. So for USAID, we have supported the institutionalization of the National Community Health Assistance Program since it was launched in 2016. And USAID being the largest donor in the health sector, or one of the largest donors in the health sector, have and continue to support the Community Health Assistance Program. So through our catalytic investments, whether it's a bilateral program or the field support activities, we continue to work with the Ministry of Health to make sure that the National Community Health Services policy and strategic plans are disseminated and rolled out across the country. We have also supported the recruitment, training, equipment, remuneration of community health assistants and their supervisors across different counties through different implementing partners. And we also we supported the standardization of a national curriculum for community health assistance program. So 2016, when the program was launched, we had to work with the government and support the government financially and technically to put in place a harmonized curriculum. Because prior to that, we had a varying implementing partners supporting training across different modules, singular modules, for community health service providers. So over the years, we have also supported, putting in place a designated supervisor for community health assistance, where we all know we have community health services supervisors in place. We do not just support the policy bringing these people into place, but we also procure logistic support for them. I'm getting a feedback which I wasn't getting before. Is everything okay?
I believe so.
We put in place logistics support, that is making sure we procure and provide motorcycles for these community health services supervisors, including the maintenance of these motorcycles. Over and above, we have continued to support the financial incentives to community health assistants and community health services supervisors across counties where we support. And then in multiple counties where we also support through other implementing partners, like I mentioned earlier, bilateral agreements with organizations or through fee support buy-ins for different organizations. One of the things that we felt was very critical to the community health assistance program was making sure we had the community-based information system in place. So USAID, through our implementing partners, supported the development of a community-based information system, which is the platform on the DHIS2 of the Ministry of Health. So this system, helps us to be able to access community health information from across the country making sure that we know what community health assistant in every place. So as, for example, as James mentioned, where he works in Bombing County, we are able to know and see where James is, what works he does in his community, and that is reported through the CBRS. I think one of the things that was mentioned in is what our priorities will be going forward. And our priorities have been, even prior to 2016, making sure that we have a national standardized program in place, is to make sure that we have cadres of worker or service providers reaching to the most vulnerable population in high-to-reach areas. That is still a priority for USAID. And we also would like to see a holistic approach to the health workforce, making sure that community health assistants are incorporated as part of the health workforce. I think one of my colleagues mentioned that. So USAID continues to support health system in general and making sure that the community health services activities and service providers at the lowest level of the health system is incorporated and included in all of the health workforce planning. These are things that we think when we prioritize, we ensure that we have a whole of health system approach. We also are really interested in making sure that CHAs are recognized, they are respected, they are empowered, they are equipped, and above everything, they are paid for the services that they provide, because they too are putting in time to provide services to serve their communities. And as James mentioned, some CHAs do work more than 5-6 hours to get to one community or to provide service or to even come to a health facility, to get information, to get trained and what have you. All of these things continue to remain priorities for us to make sure as we continue to implement community health program in Liberia, these things are addressed, and community health assistance well-being, is really at the center of all of what we do. We are also really glad that this theory of change, related to the theory of change, we are happy that this was applied to Liberia, and we think it's a good tool that can be used, because supply chain, as we have listened to from, as I have listened to from other panelists, is one of the greatest challenges that community health workers are faced with in Liberia. And even overall within the health system, supply chain continues to remain a challenge. This is one area in which USAID has invested a whole lot, and we continue to invest, ranging from warehousing, from distribution, quantification, and all of that. So it's really critical that it continues, to be on the radar of every stakeholder, so that it is addressed. Because supply chain for service provider at the lowest level, is something that boosts their morale, is something that helps to make sure that services are delivered. So from what I have read, I think that the tool looks across different parameters of the community health workforce, as I mentioned earlier. When you take into consideration staffing, you look at skills, you look at motivation and workforce, it's really critical that community health workers or community health assistants have what they need, to do the work they do. Like I mentioned earlier, we are providing incentive support, and it's really critical that what we pay for, we get the value for the money we spend, and we are able to have people doing the job that they sign up to do, and they remain motivated and engaged by their communities. It's really important that the communities get the benefit of what we say we were going to do through the community health assistance, by making sure we equip them and give them the necessary supplies that they need so that they are able to serve the communities. USAID remains engaged with the government of Liberia, the Ministry of Health, and continues to support across all sectors of the health system to ensure that supply chain issues, community health workforce, motivation for community health, skills development for community health are all prioritized. And these are investments that we continue to support the government with, the Ministry of Health, the Community Health Services Program, and other line of programs within the ministry. Over.
Thank you very much, Jannie. And thank you to USAID for these priority investments, especially in institutionalizing the policy around the National Community Health Assistant Program. And as well as I was excited to hear about the community-based information system that will provide much more of the detailed health information that's necessary. So let's try to go back to John Harris. I have now enabled his mic. John, are you there?
Yes, I'm here. Thank you.
Okay, great, fantastic. Thank you.
I'm using Arthur's computer
Okay.
For the discussion. Okay. So let's just go straight into it. Yeah.
Yeah. Yes, please do.
I have about 5 priorities. You asked me on the priorities. We have about 5. We love to see a strong supply chain system at the community level, including the national system, that improve availability and accountability of medicines and health products at all times. That's a high priority. We have been working with all partners in country, including the VillageReach, to improve the supply chain performance. In terms of the workforce, we love to see a well-capacitated workforce that will be in position to perform the tasks to ensuring continual availability of medicines and health products that support health services at all times. In terms of the supply chain, we love to see the robust supply chain system that supports a timely submission of consumption of issue data that informs quantification and the procurement. One of the greater issues we have is the timely reporting of consumption data from the various service delivery points. Another one said that what we intend to see at the community level, we love to see a strong government ownership of the system. We love to see the system being fully owned by government. Once the system is now owned by government, the priority becomes very thin. That's some of the issues we have right now, as explained by one of the panelists. So we are striving to see government commitment. In terms of having medicine and medical product available, besides government, we love to see on board everybody, including the partners and also people that deliver, to strengthen the procurement of medicine and medical supplies, specifically for the community health assistance program. The national government is currently striving to have medicine available for hospital, health center, clinic, and other systems. And the community have been added system on the list that expand the scope of the program, the health services. That means that you require bigger budget. So in order for us to really succeed to running the supply chain system, a robust supply chain system, there's a need to have everybody hands on deck. They mean that partner and donor agencies that are committed to strengthening the community assistance program. They shouldn't just be services and human resource. We want to see the financial commitment and actual release of funds to buy the drugs and medical supply for services to be run at that community level. We have a lot of systems in place put in by coming partner providing various systems whatsoever, but when you check into various work streams, you will not see much thing on procurement. You go often ask them, we agree, you have brought your system, you have brought the platform, whatsoever. How much do you have that you can support to buy medicines and medical supply that the community assistance program can be used to provide services? That question is a big question that we usually don't get answers for. So we have been advocating, working along with VillageReach, other partners, to see that even though we are talking about system strengthening, workforce strengthening, but we should also fight against some little funding uniquely for the community program to buy medicine and medical supplies. So there's I think I heard from you saying that 20% of medicines that are delivered to the country are allocated for the community assistance program. Well, that is not an established system. That's been a rumor here because we don't have any data source for that. But the fact of the reality is that the community assistance program are not getting the level of supply they should be getting because of the limited quantity of medicine and medical supply. But if we can get support from all areas from government and the donor agency, and we allocate specific funding to procure some medicine for the community. I think we'll be able to overcome all of these. These are the 5 areas I decided to put forth in this particular discussion. Thank you.
Thank you very much, John. Excited also to hear about the need for all hands on deck and of course this whole financial commitment area. All right, I'm going to now, let's hear from Dr. Lennie Bazira from the Community Health Impact Coalition. CHIC, Community Health Impact Coalition, CHIC, believes that community health assistants should be salaried, skilled, supervised, and supplied. You may have all heard this is their slogan, the campaign that they have been advocating for several months. So basically, can you tell us what does this mean in practice? And is this idea compatible with the 4 pathways in People That Delivers theory of change, which states that the staffing, skills, motivation, and work conditions need to be addressed if patients are to enjoy access to health commodities? And then maybe also the question around, are there any promising practices from elsewhere that you can point to that have increased patients' access to health commodities? So over to you, Lennie.
Thank you, Dominique. Good morning, good afternoon. As mentioned, Community Health Impact Coalition, we exist to make professional community health workers the norm worldwide. We are a coalition of organizations that are aligned in terms of mission in more than 40 low and middle-income countries. But very briefly, before I answer your question, just as a recap, 70% of community health workers, majority of whom are women, they are not salaried, they are not skilled, they are not supervised, and they are not supplied. Many of the health systems are not set up to make community health workers effective. And therefore, as such, they fall short of their potential and the patients suffer, which is basically a human rights issue, a labor issue, and also a gender issue. So in practical terms, when we talk of community health workers having those 4 critical skills that we fondly refer to the 4 S's, what does it mean? And how is it aligned to people that deliver theory of change? When we say skilled, it means there are proper guidelines on how community health workers should be provided training, both pre-service training and in-service training. That means before they are deployed to serve the communities, they go through a proper training with a clear they are to offer services as per the health package we are mandated to provide. That way, it aligns with your motivation, because when somebody is equipped with the skills that they need, they feel more confident, they feel motivated, and they gain the trust of the communities when they go to a household, because they are able to address any conditions that may arise. Supervised. For us, we believe that every community health worker like James should have a dedicated supervisor linked to a facility where they refer their clients. That means that person is there for community health workers like James to offer them feedback, ongoing mentorship, one-on-one coaching, so that they can continuously improve their skills. And that way they're able to offer quality services to their patients. Because when you are deployed to do the work that you do, when you're supervised, you get feedback, you feel more confident, you feel motivated, which actually also aligns to your theory of change. The third one, we talk about supplied. I think this whole webinar is all about supplies. For us, we mean community health workers, they need to have the drugs, the tools to be able to offer the services that they are mandated to offer without stockouts. We've heard that a third of the time they face stockouts, and they lose trust from the community that they serve. So in practical terms, basically that's what it means. And I want to get into that because that's how this webinar we've all been talking about the supplies. The last but not least, which is critical, salaried. 85% of community health workers in Africa are not salaried. And when we use the word salaried, not a stipend, not an incentive, not an allowance. We believe community health workers, because they work, they should be paid a proper salary that is commensurate with the work that they do, that is aligned with the government minimum wage, and that includes benefits like insurance. Like James mentioned, they work long distances, they face dangers. But when you give them a stipend, you're not catering for the other aspects of what we talk about when we say salaried. So basically, in a nutshell, that's what we mean by those conditions. And that's what as CHIC we continuously advocate for. However, we go beyond the four. We also believe that for community health workers to be effective, they need to work, they need to be accessible. That is within communities where they come from, like Liberia has already had a policy in place. However, James mentioned they still have to serve satellite communities where they don't come from. Accessible means they're within the communities and they can easily reach their patients when they are called upon. Proactive means that actually they are able to address conditions when they arise, like being part of the emergency response, disease surveillance, and others. Work within a robust health system. If community health workers are provided what they need, but the health system in which they work is weak and fragmented, they won't be effective. So we also advocate for community health workers to work in a supported, robust health system as part of the whole primary health care system. And then, of course, be a part of the data feedback loop. As you mentioned, when they collect data, they don't get the feedback. They need to be able to know that, are they reducing maternal mortality? Are they reducing infant mortality? That way they get motivated. They know that the work that we are doing actually is yielding results. But also they can feed back to the, let's say, the supply chain to kind of like say, these are the common diseases in the communities where we work, and so stock up these commodities or these drugs. That's what we need. And that way governments also can become more efficient in terms of what drugs, what supply do they need. Because community health workers live in the communities, they know what is happening. And the next question is, are there promising practices that we have seen? Yes. CHIC, we have been advocating since 2019, and we are seeing very promising practices in some of the countries. I'll mention a couple because of limitations of time. Malawi has a policy in place where actually community health workers, known as their disease surveillance assistants, are part of the government payroll. So they are salaried, they are supplied, they are supervised, and it's working. If Malawi, a very resource limited country on the African continent, can do it, we believe others can follow suit. Ethiopia has had a very successful community health extension worker program where they also, again, they are part of the government payroll, they are supervised, they are skilled, they are supplied, and they are motivated. Brazil, going to Latin America, they have over years have a very strong community health program where community health workers, again, they are supplied, they are salaried. And when you look at the health indicators in Brazil, they are really very good for a resource limited country setting because they have had a very pro CHW policy in place. And more recently in Kenya, the current government has passed a policy where community health volunteers, now renamed as community health promoters, actually they have mandated them to get, it's not a salary yet, but at least a stipend that is regulated. But most importantly, it includes contribution to the National Health Insurance Fund so that when they are sick themselves, they can get the services that they need. And just a couple of days ago, again, the president announced that they are going to designate a toolkit, which includes the supplies that they need and commodities to be able to support the communities where they serve. So yes, our advocacy is yielding results. We are seeing countries move the needle. We are not yet there 100%, but we do believe that when we advocate, and we have trained thousands of community health workers to speak about their issues, because we believe that we shouldn't be speaking about community health workers without them in the room. When we support them with advocacy skill and they speak up and we support them, policies do change. And again, to bring it back to home supply chain, during the COVID-19 pandemic, more than 18 personal protective equipment were given to community health workers. And those community health workers who were supplied with PPEs were able to prevent the spread of COVID-19 and also improve the management of the COVID-19, especially on the African continent. Again, we have also, as community, as CHIC, we research to influence guidelines. We have seen a WHO incorporate our best practice 7 out of 8 into the current national guidelines for community health worker programming. We are starting to see other funders like UNICEF, others kind of like set the stage to support community health worker professionalization as we fondly call it. So with that, I will end there, but I really believe that radical collaboration like we believe at SHIC and also with PTD, does yield result toward professionalizing our community health workers. Thank you.
Thank you, Lennie. Thank you very much. That was really excellent. And basically the message being, you know, let's all put in place a pro CHW policy. And that way we can really start to reduce that number of percentage of those that are not salaried, because that's a very high percentage. We're now going to go to round two. We have 2 questions. And I know we're already at the top of the hour, but hopefully many of you can still stay with us for at least another 10 to 15 minutes. Be for Jannie Horace, and then after that, we'll wrap it up. So back to you, James. It was very interesting to hear from you as well. And as Lennie said, you know, we need you to be part of these kinds of conversations. It was one of the reasons as well that our study spoke directly to 48 community health assistants and their supervisors to really hear the voice of the community health assistants in Liberia, so that we can make, you know, informed recommendations. So basically my question to you is, what do you need from your government to better serve your community? So over to you.
For the question, what we need from our government to be able to better our community health system program, we want to make sure that government, we have regular supply of commodities in our community. Regular supply of our commodity in the community will help to strengthen the partnership between the community and the community health assistant in terms of trusting one another and working along with one another, making sure that those conditions for which we were trained to take care of are taken care of. With so doing, the people in the community and us will be able to work together to better our community so that we can build a very strong health, community. Secondly, we want government to make sure that we are trained regularly. At least after every 6 months, there should be a refresher training for us that will enable us to be effective in delivering our services to our community. Because remember, we are not professional health workers, but if we are trained regularly, we will be able to always be on track of those information that are given to us to be able to use them to better our community health programs in our own community. Thirdly, we want for government to make sure that there is effective transportation means for referral in our communities. For example, in Bomi, we have 1 ambulance, like I've always said. You notice that from Bomi to Swemaka in Tokman City, where the county health team is situated, you see that it is 4-hour drive from Tokman to Swemaka and beyond. If the ambulance is in Swemaka, for example, each of the 5 administrative districts that will be in need of the ambulance will not have access to the ambulance. At the end of the day, either the mother will have to spend plenty of money to take the child to the health facility, or the pregnant woman will have to sit on motorbike to go to the health facility for delivery, or maybe they will refer for a danger sign. They will either have to sit on the motorbike to go to the health facility to be able to access health assistance from the facility. That is not actually good for our program. So we're asking the government will make sure that there are ambulances in each of our districts to be able to effectively transport our people to the health facility. We also want to say that government should be able to put us on salary, because the incentive that is given to us, we are told that we're supposed to work 4 hours every day, but we work beyond 4 hours. Because every time there is a need for us to work, we will have to work, whether it is in the night, whether it's during the day, wherever the circumstances may be, we must be able to provide services at all times at the level of the community. So government should be able to put us on salary, because we are afraid that when partners leave us today, this program will not continue, because the partner leave them, there will be no incentive. And nobody will want to work in the absence of motivation. So we want government to make sure that we are put on national payroll because we are health workers, so that we can be able to be paid regularly as they do for the other health workers. We are at the front of health crisis in our country. Whenever there's a health problem, we are the first responders. We go to make sure that the information is gathered and is sent over to the health facility. Now, we also want government to see reason to give us scholarship program to help those of us who are interested in becoming professional health workers in our community. Government should be able to give us scholarship so that we can be able to learn and become health professionals. We come back to serve the community. When that is done, the community health program will be, very good for our people. Government should do that for us because you see the issue of going to school is very difficult in our community or in the country. But if government provide us scholarships, some of us who have interest in the health program, that will also be good. It will be a boost. The other colleagues that will join us, we want to make sure that they work effectively to serve our community. If that is the case, I think that would be a very good thing if government do that for us. Government should also make sure that the partners who are providing health services are encouraged to be able to reach beyond other places. There are still places in Liberia, in Burma, that this program have not been able to touch in terms of having an assigned CHA in these areas. So that makes a CHA to work long distance or distances to cover all community activities. So thank you so much for the question. And this is what we want for government to do for us. Thank you.
Thank you, James. So let me just quickly recap. It's about regular supply, the trainings, refresher trainings, effective transportation for the referrals, putting you on salary, and then, of course, the scholarships to become professional health workers. And of course, then partners being encouraged to go beyond the places that currently are not being assigned to community health assistance. So that's fantastic. Thank you, James. So I'm now going to go to John Harris. And really then the question to you is, what is your future strategy for community health assistance? And has PTD's work in Liberia through our theory of change to identify areas of improvement, has that influenced your future priorities? So over to you. John, are you there? I see that author's mic is muted. Can you unmute yourself? Okay, I think in the meantime, I would like to then go to the Q&A, actually. I saw one question, which was more like two questions, what I thought might be excellent if, let me see. Okay, let me just see. John just said I need to unmute Arthur. So let me just go and find Arthur. Okay. All right, he has been unmuted. All right, I'm going to go to the one question asked by Lior Miller, and it says, so thank you for a great presentation so far. Are there any lessons learned for countries that are expanding CHW's scope of work to include basic curative care in terms of how to revise the supply chain and logistics system to accommodate new packages of care, where supply chain used to stop at the health facility level because CHWs only provided preventive care, but are moving to be able to provide curative care. So wondering if, is this Lusuf, would you be able to answer this question from a VillageReach point of view? Lusu, are you there?
Yes, I am here.
Yeah.
Can you hear me?
Yes, I can hear you.
Yes. So in Liberia, currently, the CHS provide curative services, just like James mentioned. Mainly, they do treat malaria, uncomplicated malaria, and also uncomplicated pneumonia. So right now, in the new policy, they have also expanded the scope of the work that the community health workers will be doing. Now they have included screening for NCDs and also mental health. So yes, the supply chain also is updated based on what has been approved in the policies. So right now, what that means, a good example would be during the COVID-19 pandemic, whereby the community health workers were also were recognized as the first point of care to identify COVID-19 cases in their communities. So they were supplied with PPEs so that they can be able to protect themselves. And also equally so, a good example is there is a program currently being piloted in Liberia for eye health, where community health workers have also been trained to screen for basic eye issues, and are able to also prescribe eye glasses. So the supply chain has equally included these on the reporting forms, and also supported with both the trainings and making sure that the data that is generated can equally be interpreted to inform the forecasting assumptions, so that we can quantify the right commodities for the CHAs. So I did miss the last part on the ELMIS. So if you don't mind, can you repeat that for me?
Yeah, that says, and does Liberia have any ELMIS capabilities to address reporting and data delays?
So the way the system is set up is data is supposed to be submitted on a quarterly basis. So technically, the system is open for people to still submit data. So it's never closed. So whether your data is late, you can still submit it. So, but however, VillageReach at the moment is working with the Ministry of Health and other partners to digitize the community-based information system that Jannie earlier mentioned. So basically what that is going to do is to make sure that on a monthly basis, that data is submitted in the ECBIS. And as soon as the quarter ends, it becomes readily available on the ELMIS platform. So we are working with the Ministry of Health and also the development partners to make sure that the ECBIS is integrated with key national reporting systems. So we're still learning, and we're still in the pilot phase of this new digital tool.
There was a question as well from Rachel Hampshire around the private sector, and if the private sector could be involved in addressing some of these challenges. So Lennie, I was wondering, from a chic point of view, is this something that you have been looking at as well, as to how private sector can be involved?
Yeah, thank you, Dominique. And I know we have run out of time. So what I have done, I have put in the chat a link to our research publications. We have more than 100 papers that you can browse through and find relevant topics. But to answer your question, yes. For us, we believe that government alone cannot do it. Private sector are part of the health system. And that's why I mentioned when the health system is strong, it includes all actors, including private sector. And when we talk of the health system, it includes supply chain. So yes, private sector is part of the system, but my call would be the private sector should ensure to align to the government policies. And that's why we promote government policies that are pro-CHWs. So if the government policy clearly outlines what community health workers should have in their toolkit, what conditions they should treat, then private sector should make sure that they align with that policy and they do not introduce a vertical or parallel system, but try as much as they can to integrate within that country's health system. That way we can actually together strengthen the health system that would effectively support community health workers.
That's great. Thank you, Lennie. I'm also looking at John Harris's response to my question around sort of the future strategy for community health assistance and whether our work in Liberia has influenced future priorities. And John said that the Liberia MOH accepts our theory of change. He says, we believe this change is useful to transforming and improving the performance of the health supply chain management at all levels of the national system, and that the Ministry of Health will be adding the health logistician in the supply chain workforce to further strengthen the system. So very excited to hear about this progress that has been made. John, thank you very much for adding that comment in the chat. And as well as your question, can PTD lead the pulling of donors and partners to support the commitment to the procurement of medicines and health products purposely for the Community Health Assistance Program? Yes, we can. In what is possible in our area, then that's something that we could definitely support and commit to. With that, I think we're getting pretty much towards the end. And I just wanted to bring your attention to 2 reports that are available on the People That Deliver website. Thank you, Jonathan. So our website is www.peoplethatdeliver.org. On our website, we have 2 reports. One is the full report with the findings and recommendations from the study in Liberia, as well as a technical brief, which calls out the strengths of applying the theory of change to assess community health workers, as well as the application of it in other countries. As far as the strengths of the theory of change, all the challenges stated by the community health assistants, as well as supervisors, can be categorized within our theory of change, within our 4 pathways of staffing, skills, motivation, and working condition. This indicates that these pathways are an adequate lens through which to analyze the conditions under which community health workers can perform optimally. Not only can the theory of change be tailored to other contexts, but the diagnostic in Liberia is also transferable. Many of the findings are relevant to other sub-Saharan African contexts and rural areas in low and middle income countries. Of course, given similar disease profiles, high maternal infant mortality rates, and poor infrastructure that hinders access to health centers. Finally, I think something I wanted to know was the theory of change is a tool that has really enabled us to convene many different actors together to talk about how do we best improve healthcare in Liberia. And now, before we end, I just wanted to pass it back to Lennie for any final words from Sheikh.
Okay, thank you, Dominique, and thanks everyone who stayed with us. But I think in my closing remarks, I really want to acknowledge our special guest, James. I know James did mention he's not a professional health worker, but I beg to differ, James. You are. And that's why as Sheikh, we exist to make professional community health workers the norm worldwide. We do believe community health workers, for many patients and billions, you are the only person who would ever allow them to come into contact with the healthcare system. for majority of them, the only way they will ever get access to healthcare services is through a community health worker. So if somebody says you're not a professional health worker, then I beg to differ on that one. Yes, you are you're a professional healthcare worker. All we need to do together is through our radical collaboration to support you, to make sure you have the right skills, you are effectively supervised, you are effectively supplied, and you are salaried to enable you to do your work effectively. So that way, you are able to deliver quality healthcare services. When community health workers are supported, then communities do better, then household health outcomes improve. So I do believe, let us join the radical collaboration movement that we believe in at CHIC to make sure that we push governments to pass policies that are pro-CHWs, meaning that professionalize this group of healthcare workers that are critical if we are to achieve our universal health coverage by 2030. Thank you all for coming, for joining us, and together we should be able to improve the support we offer to community health workers and improving health outcomes in Africa and across the globe. Thank you very much.
Thank you, Lennie, and thank you to all the panelists and everyone in the audience for joining us today. Very much appreciated. If you're interested in learning more about People That Deliver, we have a number of resources listed here on this slide, as well as our social media handles and our email info box. So we look forward to hearing any comments, questions you have. If you have any comments for the panelists, please also send those to us and we can forward them to the panelists. So again, thank you and have a great rest of your day.